Dr. Yoshimura. He is with us. He is, can I invite Dr. Shinchi Yoshimura? He's professor and chair at Department of Neurosurgery at the Hugo College of Medicine in Japan. And he will be talking to us about complications in endovascular intervention. He does a lot of interventional neuroradiology, and he will be showing his presentation now. Dr. Shinichi?
Okay, do you see it?
Yes.
Yes,
Hi. Hello, everybody. It's a great honor for me to present our experience of the endovascular therapy for large or giant aneurysms. Okay. This is our college named the Hyogo College of Medicine. It is at Nishinomiya. Where is Nishinomiya? It is close to Osaka. It's actually between Osaka and Kobe. Here is our institute. This is my personal experience of the treatment as a neurosurgeon. My total case is over 5,000, and among them, more than 2,000 cases are aneurysm treatment. The number of treatment of cerebral aneurysm is increasing by year like this. And in my department, open surgery is done in around 40% of the patient, and endovascular therapy is in 60% of the patient, according to the patient aneurysm anatomy and systemic condition. Endovascular therapy was performed more than 500 people in 5 years, and the percentage of coiling is 44. Stent assist coiling is 41, and the flow diverter was used in 15%. This is a summary of clinical result of our aneurysm treatment for unruptured one from 2016. And in endovascular therapy group, we experienced a complication in 2.5%. It is not so much, but look at this. This is a summary of complication in endovascular therapy for cerebral aneurysm. Among these 5 patients, all were in large or giant aneurysm. And among them, this is a very light, mild complication, double vision worsening. But the other one, hemorrhage, and this might be due to rupture of the aneurysm. I guess it is 1 month after the procedure. The timing was 1 day, 1 week, 3 weeks, and 1 month. So complication in large or giant aneurysm done by endovascular therapy were mainly due to hemorrhage. So, pipeline is a major device as a flow diverter for cerebral aneurysm. It is most frequently used in the world. And please look at this animation. Most of you already saw this animation. If aneurysm is located at the paraclinode portion, this device is very effective, like this. Just deploy in the parent artery. That's it. It's so easy. It's so simple. It can be done under local anesthesia. Actually, my main series of the pipeline is done under local anesthesia. The aneurysm shrinks like this. So this is a typical case, 55 years old male showing visual disturbance. And this patient was actually a medical doctor, radiologist. He noticed left visual disturbance, and he did his own MRI and knows his aneurysm like this. Suprasellar mass lesion was detected. And he came to me and he showed this MRA and the maximum size was more than 15 millimeter. So he already investigated the publication and requested me to perform a flow diverter treatment without coiling, okay, because of the better visual acuity improvement. So I followed his request, just deployed a single pipeline like this under local anesthesia. And this is just after the treatment. And 6 months later, aneurysm size is smaller than the just after one. And 9 months later, aneurysm was gone on MRA and the visual disturbance was completely improved. This is a follow-up angiography pre and after the treatment, 9 months later. Look at this, aneurysm completely disappeared. But we experienced serious complication in this 74 years female. She had a progressive visual field defect like this. Left eye was almost blind, and right eyes visual field was getting smaller. And the previous surgeon judged the aneurysm was uncreepable because the IC perforator were running along the aneurysm wall. So we thought that what kind of options are available for her, clipping, parent arterial occlusion with or without bypass, flow diverter with coiling, or flow diverter only. We had a big discussion with that, and perforator adherence to the aneurysm wall made difficult clipping. Okay, risk of anterior choroidal artery thrombosis due to hypoplastic PCOM, we gave up to perform a high flow bypass plus parent arterial occlusion. And I think this method, flow diverter plus coiling, might be better in terms of to prevent delayed rupture. But patient and patient family strongly requested to perform flow diverter treatment only without coiling. So we followed again this method. This is a movie of flow diverter deployment for her aneurysm. Okay. It was very difficult to navigate the microcassette to M1 portion. We went around the aneurysm like this, and we inserted another catheter to embolize the aneurysm, okay, in case of something happens. And we connected 3 flow diverters, 3. It's very expensive treatment, but I could manage to deploy 3 stents. Look at this. Contrast media was stable in the aneurysm. So we are so happy with that, but it was suddenly disconnected. So now we navigate the microcatheter through the disconnected 2 stent like this. Now I explain like this. This is just after deployment of 2 flow diverter. Look at this. This deployed very well, seems to be well, but it gradually shrinked and disconnected. Okay, so I navigate the microcatheter between these 2 stents and connected like this. So we were happy with that and start to select the additional pipeline. But anesthesiologist reported blood pressure elevated gradually. We requested to lower it, but the pressure was still elevating. So I felt strange and did angiography and look at this. ICA was occluded maybe due to the thrombosis, but contralateral angiography showed the actually elevating the intracranial pressure. It means aneurysm ruptured. during the procedure. So we immediately embolize the aneurysm and isolate self. Fortunately, there was a little communication from the contralateral A1 side, but finally we lost this patient. So what was the cause of rupture? It ruptured during selection of flow diverter. We didn't touch the patient at the time. So maybe compression of the aneurysm wall by the catheter, or the aneurysm wall was injured by an edge of disconnected flow diverter during insertion of microcatheter, or flow stress by turbulent flow by disconnection of flow diverter cause rupture. Who knows? But maybe one of them. So we try to fix our method. Short course of deployment is better. So sometimes we have to go around in the aneurysm to navigate the microcatheter, and we try to deploy like this, but it causes rupture. So we have to go around the aneurysm sometimes, but we have to straighten the catheter by inflation of balloon or something, and deploy stent straightly. This is the ideal method. But sometimes it is not easy. Go around the aneurysm, pull the catheter, and try to deploy stent, but it may sometimes need 2 or 3 flow diverter. It lead to migration of the stent system like this. So we saw that this method, okay, straighten the microcatheter, and after straightening, we embolize the aneurysm, and by disanchoring, we could deploy pipeline like this. So it is the best one like this, okay, you saw. But if it is very difficult like this, we have to deploy coil and flow diverter. But mass effect may remain. But in this 80 years old female showing hypopituitarism and visual field defect, we did the plan 2. Okay, patient had such a giant aneurysm, and we delivered coils like this, and this is just after coiling. Afterward, we deployed pipeline like this. So aneurysm was completely obliterated during follow-up. But her visual acuity was not recovered, but we saved her life. So aneurysms difficult to treat by flow diverter are as follows. First one is a tortuous access route. Okay? Navigation of guiding or microcatheter is difficult. Giant aneurysm. Complication rate is reported to be higher compared to large aneurysm or smaller one. Fujiform or aneurysm having branch from the dome, there is a risk of thrombosis in branches and perforators. Maybe this is maybe a basilar trunk aneurysm or MO aneurysm. Ruptured aneurysm in acute phase is not, flow diverter is not reimbursed in our country. Delayed rupture may happen. Okay? And hemorrhage, if patient having hemorrhagic disease like gastrointestinal or women's disease like uterus myoma or something, antiplatelet may cause hemorrhagic problems. So we cannot administer it. So it is not good for the pipeline treatment. So our experience of pipeline is now 100, but in 90 patients, we experienced this serious rupture. And another one is worsening of oculomotor palsy. So basically, the treatment is safe, but we have to carefully select the patient. So recently, endovascular therapy is rapidly increasing, and many patients request it. However, we should select a surgical method when it is safer due to patient anatomical and systemic condition. Okay, this is extra appendix. Annual trend of cerebral aneurysm treatment in Japan. Okay, rupture, clipping for rupture, unruptured are decreasing, and both unruptured or unruptured endovascular therapy are increasing like this. It is almost the same within 2 or 3 years. Okay, 10 or 20 years ago, it was like this. Surgery and endovascular therapy was like this. However, now it is like this. Okay, so it's time to shake hands. Maybe now it is time to be a hybrid neurosurgeon like us and to do endovascular therapy and surgery. So I'm always saying to the young fellow, why don't you start endovascular therapy together with surgery? Is it possible? Nothing is impossible to achieve. Okay, we have actually many overseas trainees and visitors like this. We are so happy. They are from Indonesia, India, Nepal, Vietnam, Colombia, Nepal, Thailand, and also even from Nigeria. We are happy with them. Okay. We are proud to be a WFNS postgraduate training center, and hopefully we can see you, young fellow, in Osaka or maybe in Kobe. Kobe beef is waiting for you. Thank you for your attention.
Thank you, Professor Yoshimura. That was an excellent presentation. Thank you. Thank you very much. And you spoke about hybrid neurosurgeons, and it is becoming a very important armamentarium. I think young neurosurgeons should train in both open and endovascular, because then you have the option of selecting the right treatment for your patient. You know, use the aneurysm morphology, and then you're able to select the right kind of treatment for all your patients. We in our department also do both. Even I'm trained in both open and endovascular neurosurgery. And to say the least, flow diverters are a good option, but yes, complications can happen. Even I have seen one where we had a supracranoid huge IC aneurysm, and the patient did well for 3 days after deployment of flow diverter, but then suddenly on the third day, she succumbed, and we did an autopsy, and we could see that the flow diverter had come out of the vessel. I mean, the whole aneurysm ruptured. Yeah. So I have seen one complication of a flow diverter, but otherwise they are pretty good tools and they do well. So thank you, Dr. Yoshimura.
Thank you. Thank you, everybody.
Do we have any questions?
Yeah, actually, I have a question, if it's possible, if you have a time.
Go ahead, Dr. Rosanna.
No, I'm just impressed by the fact that you did 67 cases under local anesthesia. I mean, this is the first time that I, to be honest, I heard that, I mean, they stand, in session, because usually they are under general anesthesia. So.
Oh, really? Yes.
Yeah, we do under general, to be honest. Yeah, in the department where.
Japanese patient are so tough.
So still, because and do you do also the double anticoagulant treatment for you do the aspirin for life, and then what do you use usually?
Right. A key point is to test the antiplatelet reaction of the patient before the procedure, because Asian shows a higher percentage of the resistance to the clopidogrel, right? So in that case, we switched to the recently new tenopyridine medicine like prasugrel or some other.
Prasugrel. And then you do prasugrel for 6 weeks or for 6 months. How much do you usually, and how long do you?
Usually 1 to 3 months. We will stop prasugrel and continue aspirin.
For life. Okay, that's fine. Okay. Thank you. Thank you. Very nice. Beautiful presentation. Wonderful. Thank you.
Thank you, everyone.